us. I'd just like to give a very brief introduction about imaging the eye actually. As we have all seen that the importance of imaging in ophthalmology has taken a quantum leap over the last few years actually. And we seem to be headed into very exciting times actually. Imaging has become so important that generally in our clinics, we can't do without the OCT, we can't do without the fundus camera, and so many other new technologies. So I think that imaging is a critical part. It's become almost a separate subspecialty in ophthalmology. And that was the purpose behind starting this program. And we thought we'd bring you some of the best names who've done a lot of work consistently over several years to this meet actually. And I'd like to introduce you to Dr. Rajiv Raman, who is my co-chairman. He's senior consultant at Sankara Nethralaya, and we're doing this program jointly. I would now ask Dr. Rajiv to introduce Dr. Parveen Sen, who's as she said, the opener for this meet. Welcome, Dr. Parveen, and we look forward to hearing from you.
Thank you, Dr. Nangia.
Thank you, Dr. Vinay Nangia. It's a real pleasure being here, and thanks for the great initiative. As you rightly mentioned, the imaging is now something which we cannot go without, and especially I would say not only in retina but glaucoma, anterior segment, and the way you have devised this program, having all the experts in various specialities and teaching some nuances of imaging. So we will start with the retinal imaging, and I have pleasure to introduce Dr. Parveen Sen. She is the senior consultant Vitreoretina Services at Sankara Nethralaya. She has been my colleague for last 2 decades, and I would say she is master in many things. She is master in age-related macular degeneration and IPCV, and her subject the hereditary retinal diseases, and one of the opinion leader of our country. I will not say not country, but even in the whole Asia Pacific on retinopathy of prematurity. A multifaceted lady who has a track record of several publications in all these fields, and she will today share with us the nuances in the imaging for an important mimicker of age-related macular degeneration, that is polypoidal choroidal vasculopathy. And she has been working on that. She has seen the era from ICG, and when this diagnosis of PCV the term was coined by Dr. Yanouzi, and the initial series she has seen in India, she has gone through all the era, no ICG, with ICG, with OCT when it started, the time domain, the spectral domain, the swept source OCT, and now she's working on the angio OCT. Dr. Parveen Sen.
Thank you, Rajiv, for a very kind introduction. And I must begin the Sunday morning by congratulating Dr. Vinay Nangia for a very, I think, innovative platform for imaging, where he is going to combine the interior segment as well as the posterior segment imaging. And we have the leisure of discussing one disease in a day, which is something which we don't have it otherwise when we are rushed for time and delivering 5 minutes, 10 minutes, 12 minutes lectures. Sometimes you're not able to do justice to the topic that you are going to study. So this is going to be a learning experience. And as Rajiv mentioned, I have come through a long years, and I remember when first OCT came, a lot of us didn't give it too much of attention. We thought this is just another diagnostic modality. It won't stay here for too long. It will be there for one more machine, and then slowly it will fade away. But it has totally revolutionized a lot of things and brought in so much of stuff, and how we look at and how we are understanding things has changed, and especially where PCV is concerned. I think the knowledge and understanding is still evolving. So I will take you through my experience, and as you see my slides, you will realize that I will go somewhere with VOCT, somewhere with SDOCT, somewhere with swept source, somewhere with OCTA. So that also shows my journey. So these are cases which I have accumulated over last 2 decades almost. So with that, I begin my topic for the day.
If you want to go
And
and see, I'm all right actually. You can watch it nicely and yeah.
so,
You can just drop by once in a while.
so are you able to see my slides?
Not,
No,
not
no,
as yet.
not yet.
Yeah.
No, can you again share it?
You can see my slides? Yes. Okay.
Yes, now we are seeing.
All right. So I begin the deliberations for today with imaging in PCV. And first, I would like to introduce you to a few terminologies so that once we go through the session, we know what we are all talking about. So what is, first of all, a pachychoroid? So any abnormally thickened choroid that is seen on OCT is a pachychoroid. And the dilatation is of the choroidal vessels, mostly it is the hallux layer which is dilated. And the subfoveal thickness in a normal subject is usually less than 300, and if more than 300, it's considered pathological. So this can be diffuse. Here you can see a huge pachychoroid, and it is present almost all over the posterior pole, or it can be focal. Here you can see a very small area of pachy vessel, which is seen just below the pathological leak, which is seen. So what are pachy vessels? So we see these are the enlarged vessels which are seen on OCT, and on ICGA they appear as dilated vessels. So vis-a-vis, what is choroidal vascular hyperpermeability? So structurally dilated vessels are called pachy vessels, but if they leak on ICG, it's called vascular hyperpermeability. So all choroidal vascular hyperpermeability will definitely have thickened choroidal vessels, but the reverse is not true. So not all pachy vessels will leak on ICG. So this is what you have to understand. And the next thing to understand is when we talk of a pachychoroid disease, just normal thickening is only pachychoroid, but when this thickening of hallux layer starts giving rise to compression of the other layers of the choroid, this is the figure which shows you that the outer layer is hallux, the second layer is satellus, and the next is the choriocapillaris. So as the hallux layer thickens, it compresses the satellus and the choriocapillaris, and because of the thinning of the choriocapillaris, you may have ischemia, and this can give rise to the outer retinal nuclear layer thinning or neovascularization. So this is how the pachychoroid disease starts happening, and this can be either in form of a pachychoroid pigment epitheliopathy, CSC, PNV, which is pachychoroid neovasculopathy, or pachychoroid choroidal vasculopathy, which is what we are going to discuss today. And the neovascular component is largely seen in pachychoroid neovasculopathy, in neovascular CSC, and in PCV. It is not necessary, it is not essential that one spectrum has to give rise to the other. You can have one patient can have only CSC, the other can have PNV, or you can have one eye PNV and the other eye can have CSC. So it is a mix of things which can happen. So with this little background, we go on to the pachychoroid vasculopathy. This disease is one of few diseases in retina where the spectrum of presentation is really wide. You can have orange-red nodules, which can be sitting there absolutely asymptomatic, or it can create havoc and lead to a lot of hemorrhages or exudation. So there are two types, exudative or hemorrhagic, where they are predominantly the polyps leak blood, or they just cause leakage in form of exudation. And the two major components are the branching vascular network and the polypoidal lesions, which we'll be talking about. And depending upon the shape and size of these polypoidal lesions, you may have a single polyp giving rise to solitary PCV, or you could have a cluster-like polyp giving the grape-like lesions, which are multiple polyps sitting together. Or you could have a peripapillary lesion, you could have a macular polyp, or you could have a peripheral PCV, because here the polyps are in the periphery. So the location of the polyp is determining the kind of or the classification of disease. These polyps can be seen on FFA and ICG, but ICG remains the gold standard because it is largely known to origin from the choroid, and because of its pharmacodynamic and kinetic properties, that it is 98% protein bound ICG, and its spectrum is such that it reflects the choroidal structure much better. So PCV is best seen on ICGA, which highlight the two components, which is the polyp as well as the abnormal vasculature. So a typical polyp is early, shows you early hyperfluorescent nodule is seen, and this is in the very early phase of the ICG. So much so that within the first 30 seconds of ICG, or even the first 1 minute, you should be able to pick up the BVN. In fact, if you miss this period of first 1 minute or 30 seconds, you may not be able to define or see the BVN extent, especially the feeder vessel. Depending upon the ICG characteristics, the BVN is supposed to be of two types. Here, what you see is an interconnecting channel. That is, you are not able to see where this abnormal vessel is coming from, and the periphery of this vessel will have dilatation in form of polyps. But here, if you see, this is the very early phase on the left hand side, which gives you a feeder vessel. This is the first 30 seconds. And then this gives rise to the whole BVN and the polypoidal complex. So if you miss this first 30 seconds, you will miss the feeder vessel. Then in the first 6 minutes, you are able to see how the polyps fill up, whether it's hyperfluorescent, and if it is surrounded by a hypofluorescent halo, that is even more pathognomic of a polyp, and presence of pulsations, which is seen on a video ICGA, is absolutely diagnostic of polyps. This is a late phase feature. Usually you can see it as late as 10 minutes after the injection, and this is a late geographical hyperfluorescence, which outlines the whole pathological area. So ICG is so important that the Everest was the first landmark randomized clinical trial which was done to look at the treatment outcomes for PCV, and they have put down these 5 criteria which are even today gold good, and they are the ones which are used for diagnosis of PCV, which is the nodular appearance on stereoscopic viewing. Stereoscopic is important because you could have other hotspots like a RAP lesion, but when you see on stereoscopic view, it will be superficial, it will not be choroidal. So hypofluorescent halo usually also denotes an active polyp, and an abnormal vascular structure, pulsatile filling of polyps, orangish subretinal nodules, and a massive submacular hemorrhage. Because if there's a massive submacular hemorrhage, all these features will not be visualized well, but it still would signify an underlying PCV. So just to take you to one of the cases, you can see this is a 58-year-old female who presented with the 6/9 vision and actually was discovered accidentally to have these hard exudates which were present just temporal to fovea. Once we did the FFA and ICG, you can see that the early phase, the FFA is almost nearly quiet, but when you do an ICG, you can start seeing that the polyp is beginning to fill up here, and this is absolutely diagnostic that we are dealing with PCV. The fundus picture did not look very suggestive. This is the second case. So you can see the left eye has typical serous sanguineous maculopathy. There is exudation, there is hemorrhage, a mixed kind of picture. So this is almost everyone will be able to diagnose that this is PCV that you're looking at. But I will show you the photographs of the right eye. So when we see, you can see on clinical examination, the right eye almost looks normal. Here is probably a small pachydrausin is what we call it. And then if you see on FFA, you get the stippled hyperfluorescence, but ICG leaves nothing to imagination. You have a BVN, you have a polypoidal lesion, and ICG and the OCT also confirms the same. So a seemingly normal eye can have all these features, and ICG doesn't miss these polyps. So what about FFA? Is FFA totally redundant in PCV? Does it help you? So I'll show you how it helped me in treating one of my patients. So this is an 80-year-old lady who often used to come with problems of metamorphopsia. You can see she's lost one eye to extensive exudation. This was the only seeing eye, and this time she came to me with a large pigment epithelial detachment, and making a diagnosis of PCV, we gave her intravitreal injection ranibizumab. She did improve, did show response with ranibizumab initially, but then had a recurrence with resistance to ranibizumab. Now I switched over to aflibercept, and here she does show good response to aflibercept even after a second injection. But after multiple injections, while she is on aflibercept, she starts showing this kind of fluid again. So you see, this is the double layer sign is coming. So now I did the FFA and the ICG. So here you can see there is stippled hyperfluorescence. Here ICG is not picking up any polyps because we did probably give her multiple injections already. And even in the later phase, there is just a hint of a polypoidal lesion, just superior nasal to the fovea. So taking this cue from the FFA that this is where the activity is, I decided to do laser photocoagulation since this was away from the fovea to this area of FFA leakage. This is ordinary thermal laser that I did. And this is how she has responded. So you can see on OCT there was fluid here, and she did respond with the flattening of the fluid, and I could maintain her subsequently on intravitreal injections. Also, based on FFA and ICG, you can divide PCV into type A, type B, and type C. Type A, where you get the polyp with the interconnecting channels, as I described previously. Type B with polyp with BVN without leakage, and BVN with leakage. So the BVN with leakage and with polyp has a worse outcome, as we saw in the previous case as well. So what about PCV on OCT? So here you can see the typical thumb-like peaked PED, the various characteristics that you can see. If you see something like this, this is what is called the TLP, or the thumb-like peaked PED, and this is one of the most characteristic features of PCV, and along with this, a double layer sign. The neovascular complex in PCV is known to grow between the RPE and the Brooks membrane, and this causes the separation of these two layers, and they are now visible as two separate lines which are hyperreflective and giving rise to what we have, the double layer sign on OCT. A notched PED, a hemorrhagic PED, with you can see some echogenicity seen under the surface of the PED here, again pathognomic of a PCV. This picture I took specifically because it shows how a hemorrhagic PCV is different from a serous PED. This is serous PED. You can see the structures, the choroidal structures below. This part of it has got still some heme or hemorrhage which settled down here, as you can see in the photograph above, and this obscures the visualization of the underlying choroid, and this is shadowing. So this is how you differentiate a hemorrhagic from a serous PED. Multiple thumb-like PED and the neovascular complex growing on the undersurface of the pigment epithelial detachment. You can see this is PED, and you have some hyper-reflective echogenicity coming below the PED. So this is nothing but the neovascular complex which grows on the undersurface of the RPE. A notched PED, very well seen with the Heidelberg system. You can see the PED and the notch here, and this notch corresponds to the polypoidal lesion. This is again a very pathognomic features. It shows a hyporeflective lumen which is there on the undersurface of the RPE, and this again is definitely a polypoidal lesion, and you can see that following treatment it is regressing as well. So activity and response to therapy is always OCT based. You can see that the fluid present here, and after treatment it has gone, and this is very well seen on OCT. So I'm going to show you another case of here. where the patient came to us with a massive subretinal hemorrhage, and we did the FFA and ICG. You can see a little bit of focal leak is visible here. Rest of the features are obscured because of the subretinal hemorrhage. So we are not able to pick up our typical features of PCV. But look at the OCT. The scan that you take through this polypoidal lesion shows you that you have a PED below this area, you have subretinal heme, and it tells you almost everything, the multiple PEDs, the peaked PED, this is the subretinal heme which is present, and you can even differentiate it from a sub-RPE heme. So we know that it is PCV that we are dealing with. So OCT has shown you what ICG did not. And the patient underwent pneumatic displacement of the heme along with the anti-VEGF injection, and was kept on a maintenance of anti-VEGF injection. So do all patients need treatment? Well, this one had multiple polyps which was sitting, and the patient had 6.665 vision in both eyes and was on follow-up. And even at the end of 2-3 years follow-up, the patient did not have any fluid. So sometimes you can have asymptomatic polyps which are there. So, but if you decide to treat, again, you will need ICG, and this treatment, especially if you are doing a photodynamic therapy, cannot be based on OCT. So you need ICG for that to determine your best fit for PDT. To look at the regression of polyps, you will still need PDT, and it can tell you about the regression in monotherapy also. But we know that only anti-VEGF can sometimes be inadequate and cause polyp regression in only 1/3 of the patients. This can be better following aflibercept, and the response will depend upon the number of polyps, the polyp area, and the polyp pattern. Most of the times we end up needing a combination, which is a combination of PDT and anti-VEGF, and some of them do really well. Sometimes in presence of a very high RPE detachment, you may be hesitant to do PDT because of the risk of a rip involved. So here you can actually begin by giving an anti-VEGF injection 3 to 4 times, multiple times, till it flattens. And then if you see flattening of PED, then you can do the PDT to the polyp to reduce the number of injections which will be required for the patient. You must have noticed I'm very fond of using thermal laser whenever I can, because it gives you a kind of permanent closure very quickly, and especially if the ICG shows you that there is a polyp which is extrafoveal, even though the macula is covered and involved by the hemorrhage, I try and laser that area, and that definitely reduces the amount of injections that will be necessary for the patient. Here again you can see it is the leak is very close to the disc, so you may not be actually able to do a PDT, and a thermal laser just does fine, though of course you have to be careful about injury to the papillomacular bundle. Peripheral PCV, thermal laser and following ICG is the best treatment that's possible. So this is another case that I'm discussing with you. This is a patient who looked almost normal. Patient came to us with near normal vision, and OCT picked up a little bit what we call the TLP. So the slight metamorphopsia that the patient had was because of this. Now, when you have a polyp sitting right under the fovea, it's always a difficult situation. Vision is good, patient is little symptomatic because of metamorphopsia, and the treatment for this, you know, is going to be PDT plus 2 or 3 injections. So how do you convince the patient who is barely symptomatic to undergo such an expensive treatment? I was not able to convince the patient. And you see later on he came to us with a drop in vision, but almost after a year or so, with a drop in vision, with exudation, and see how the polyp has grown, and patient's vision dropped to 660. At this stage, we did a combination therapy, but there was response, but the vision was final PCV was only 660, and not we could not bring it back to 66. So what does the new kid on the block, that is OCTA, what does this show, or this has to tell us about PCV? Does it show anything? Well, it does show both the components of PCV which are seen on OCT. So, and in addition, it also shows you the flow signal, which is high where the BVN is concerned, and the flow signal is slow inside the polyp. So this is how a BVN looks like. It almost looks, this is a 6x6 scan on an ORCC slab, and this shows a well-defined type 1 CNV, and you can see this hypo well-defined lesion on the 6x6 scan. If you see the 3x3 scan, you can appreciate it much better, and this corresponds to the polypoidal lesion. So as I said that on the branch vascular network is almost picked up nearly 100% of the times on OCTA, and it is seen as a high flow signal here. And with, because OCTA is now giving us depth resolve location of the BVN, there have been many new studies and many new authors who have described the location of BVN. Most of them say it is between the RPE and the Brooks membrane, though some have said that some component may actually lie within the choroid that is below the Brooks membrane. So this is the new information which is coming from OCTA, because it is giving us depth resolved visualization of the BVN vis-a-vis ICG, which does not give you that. So nearly 100% detection of BVN is possible. This is a little difficult to understand, but I will spend a little time here because it has implications in future. So Hume et al. Had a very nice article that they have presented on features of OCTA in PCV, and they divided these PCV patients into 3 types depending upon their OCTA characteristics: type 1, type 2, and type 3. Type 1 they call the trunk type, and type 2 the glomeruli type, and type 3 the stick pattern. And they found that the trunk pattern usually had larger CNVs, the central ephovia was involved, and they had the typical trunk and the branching pattern, which is more often seen like a type 1 CNV. They also noticed that it is this trunk pattern BVN which is associated with drusen, and the subfoveal choroidal thickness was thinner in these patients. Type 2 is the glomeruli pattern, where these come as a glomerulus or a vascular network without any major trunk. Here, usually eccentric position of PCV is seen. Choroid is thicker, drusen less often. So this is again an high recurrence rates. Type 3 is the stick pattern, which again is associated with thickest subfoveal choroidal thickness, not very well appreciated on ICGA. Recurrence rates are very high, and drusen are not associated. So this is how they have seen and described. The quality probably not very good because they have used SDOCT A and not the swept source. So the BVN has been classified based on their appearance as well. So what about polyps? As you saw, we saw almost 100% detection rate with BVN, but with polyps, this detection rate is less than 50. So when they are seen, they are usually in 75% of the cases, they are seen as a hypoflow of a low, because it is hypoflow, that is why the echogenicity is less on an OCTA. And 25% of the cases, the researchers have said that they could be a hyperflow as well. So why is there a poor detection rate of polyps? It is because of the slow and turbulent flow within the polypoidal lesion, and it is also because there is associated PED, which causes incurrent segmentation, and you're not able to pick them up properly, or because the resolution of OCTA is less and the polyps are deeper. So does that mean that we should be able to pick them up better with the newer OCTA, which is the swept source? Because the swept source OCTA now uses a 1060 nanometer longer wavelength as compared to the 800 or so wavelength used by the SD OCTA. So this means a deeper penetration, less sensitivity roll-off, so better visualization. So here people have seen BVN detection up to 100%, even in ICGA, which was only 75%, and the polyps they have seen can be seen also in 90 to 100% cases. and they have said they are not dilated pouches but tangled vascular structure. So this is a study from JAMA that I'm quoting. So you can see that the polypoidal structures are seen. This is one of the few studies which is published showing results of SSOCTA. So here they are no longer hypo or empty spaces, these polyps. These are actually tangled vascular network which is present. And following treatment, these tangled vascular network is known to regress as well, as you see here post-treatment. So just to highlight the importance of OCTA, I will show how it helped me in taking care of one patient. So this is a patient of multifocal choroiditis, and he had treatment and was kind of stable. And suddenly he came with a history of metamorphopsia. And I thought he has been on and off on steroids and was expecting to see CSC here. So there is a little bit of kind of a leak which you can appreciate here, right at the fovea, but not a very typical something that I picked up. OCT, this is a few years ago. I had only the VOCT, and this did show multiple kind of PEDs, not very classic of CSC, but he was 6'6", and we thought we'll wait for a while. He did not undergo further ICG. He came back after a couple of years almost. He had been asymptomatic in between. Now he has come with a slight drop in vision, and you see how this exudation has increased. And you see this lesion. This is now a solid nodular orangish lesion which is present. And you see the OCT, it has the double layer sign and it's got a peaked PED. So I did the ICG promptly, and now it showed me a polypoidal lesion. But still thinking whether it was really PCV, because we were expecting a different scenario. OCTA confirmed the presence of BVN and the polypoidal lesion. So post-treatment with aflibercept, he is showing a good response, and you can see the response also which is seen on OCTA. So do we really need ICGA now, since OCTA is showing us so many things? So first I would like to answer this question. I could have started my talk with this, but I think here we'll be able to understand this question better. Why do we need to diagnose PCV? So various studies from India, from Japan, even we had done a study. We showed almost 45 to 50% of the patients who present to us with a serous gangrenous maculopathy actually have PCV, but the Caucasian population just said that maybe not more than 10%. But the reason was that they were not doing as many ICGs as we were doing, and when they did do ICGs, and that too using a SLO-based system, there were reports of up to 1/3 of patients having polypoidal features. And these patients respond poorly to anti-VEGF, which is the mainstay of therapy for AMD. So these are the two ways that PCV and ICG differ. So now I'm coming to the question, do we need ICG? So this question was, people got together and they tried to answer this question, and this is a recent publication in ophthalmology which has come as recent as this month, August, and there's a consensus nomenclature. They have said that we will try to put OCT or a non-ICGA based classification or definition of PCV in place, because OCT is much more widely available. And this consensus nomenclature has happened with the Asian group, with the Singapore group and the Japanese group together. And they have said that because of the newer information which is being available regarding the polyps, so we know that they are not empty pouches, we are going to call them polypoidal lesion and branching neovascular network, because it is not a normal network which is sitting there, but it is the neovascular component. It is an abnormal component which is there. They enumerated these 9 features and said and checked which one had the best specificity and sensitivity and area under the curve. So these 3, the sharp peak PD, what we call the TLP, the sub-RP ring sign, and ENFAS OCT showing you the RP elevation, these 3 put together were the major criteria for diagnosis of PCV on OCT, and combined with the others, we can reach a diagnosis. They said we could reach it in almost 80 to 90% of the cases. Your diagnosis can be correct. So why not use OCTA as gold standard? It is still not widely available. Clinical experience is still evolving. It is not further image resolution, and we need to get some more experience on it before we do it. Some newer imaging concepts, just a couple of more slides I will show you to show what more, how we are still learning. So this is a recent article in July, which has been published in October, which has been published last year. And this, if you know that there is always the vortex vein has a compartmentalization into 4 quadrants, and each one drains its own quadrant. But in patients with PCV, they saw that there was anastomosis between the vortex vein. So this horizontal raphe between the superior and inferior vortex vein is obliterated when you have PCV and you have anastomotic channels which are going from superior to inferior area. So what is the importance of this? So either this is the cause that leads on to pachychoroid spectrum, or the pachychoroid spectrum causes choroidal congestion, which leads on to vortex vein congestion. So we may actually go towards a surgical answer to a medical problem. Then, as I did mention in an article by Huang et al., there is PCV with thickened choroid and there is PCV with not so thickened choroid. So now there is a classification which says that PCV can be pachychoroid driven or drusen driven. And the importance of this is that the drusen driven PCV responds well to anti-VEGF, while the pachychoroid driven neovasculopathy with thick choroids does not respond well to anti-VEGF. And there is a genetic basis for it. The ARMS2 is the gene which is identified in AMD patients, and this is supposed to give rise, has been seen in PCV patients also, and this is the one which has thinner choroid, polypoidal lesion with BVN, and they need behaves more like AMD. So there can be, the understanding of the disease is still evolving. We still have not reached a place where we know PCV incomplete, and so many changes have happened in the last 10 years. So leaving you with this food of thought, and I look forward to the discussion from all of you and questions. Thank you.
Thank you, Dr. Parveen. It was really a nice talk, and it covered all aspects of PCV. Yeah. Before we, when you consider displacing the heme with a gas, now many times they do come with a large submacular hemorrhage, and many times you may not, though ICG is done, you may not identify a polyp because of that thick heme. So when you consider displacing, you showed a very nice case where you displaced it.
Yeah, so to cover these cases only, we have that a massive subretinal hemorrhage, even in every study, was considered a diagnostic criteria for PCV. So because it is understood that when you have this massive subretinal hemorrhage, you may not be able to see the underlying pathology. So you will not be able to do PDT and anti-VEGF. So in these cases, and especially if the history is something like less than a week or 2 weeks and it's a recent drop, you can consider giving doing a pneumatic displacement, because it moves the blood away from the fovea and allows you to do a follow-up ICG and FFA where you can pick up the lesions better.
So in the current era where majority of people don't have ICG, do you recommend them to start treating based on OCT? Because
yes,
we do know
that
now
is
that
why I showed. Yeah, the last article was for this reason, that because AMD is being so vastly treated and everybody has OCT, because DME, AMD, all these lesions, all these diseases, they need treatment based on OCT. So OCT is widely available to everyone. So this criteria or this consensus nomenclature was done with the idea whether the treatment can be done based on OCT, or rather the diagnosis can be based more on OCT.
Yeah.
Because anyway, for follow-up, we were always following and depending on OCT to tell us the response to therapy.
I think what you said is absolutely right, that diagnosis definitely can be done and it is fairly good accuracy. For a monotherapy, if you are trying anti-VEGF, you can still continue treating with only OCT information. It would be good,
Exactly.
or it would be really worth looking at, can we do a ICG OCT based PDT? Has anybody tried looking at, because that would really answer how accurate is the localization, because there you need to localize your polyp and deviant. We can do it with your NFAS imaging too. So has anybody
Actually,
tried?
you can pick up the polyps well, but I don't think anybody has tried to look at the size, and because what we are actually picking up on OCT is pigment epithelial detachment. So whether there is an underlying polyp in it or not will depend on the features, whether it hyperfluoresces or not. So doing a PDT based on just that, I don't think that will be a
Good idea. So
very
at
good
this stage, I would consider the take-home message would be that you can still diagnose PCV in a very good manner. As far as if you are planning to start with a monotherapy, you can continue treating with it. But at some
idea.
stage, when you see the response is not good, you definitely would like to have a ICG before you go ahead,
So
because you
that
may
is
need to
what
plan.
drew everybody's attention towards PCV, because it was not responding to anti-VEGF. If it were responding to anti-VEGF, then there was no need to treat it as a separate entity. Then we
Correct.
could have treated it very much like a polypoidal CNV as seen in AMD. So this is the
Uh,
whole.
Agree. The other thing is you had that polyp at the fovea. No, and definitely, as you rightly said, that you tried a combination on that. Do you feel that these are the cases you may start with only anti-VEGF, because PDT you are a bit worried about the atrophy and the other things to start with? At some stage, they may need, as you rightly said, that anti-VEGF alone may not regress the polyp. But no, these cases currently, with the knowledge of various anti-VEGF trials, do you feel starting it as a monotherapy would be a better idea, or you usually
In
treat
cases of a subfoveal polyp,
subfoveal polyp? Yes.
yeah. So subfoveal polyp, as I said, they are usually associated with good visual acuity,
Yeah.
and PDT itself you will be hesitant to do if it is associated with the PED because of the associated risk of a rip. So my go-to anti-VEGF would be an aflibercept, because it is known to cause some regression of polyps as well. So ranibizumab sometimes does not give you the regression, and the polyps go on exuding. But you can start with definitely an aflibercept, and the patient also by that time understands that yes, I have a problem here. But then to give it a definite end, if it is only a polyp and there is no PED associated with it, you can consider a PDT, which sometimes a single sitting of combination of PDT with anti-VEGF can work very well.
Good. Thanks. Do we have any questions from the
Yeah,
audience?
Rajiv, you can see the questions actually. There's a question from Dr. Anshu Arora, and she's asking, is the
Yeah.
treatment protocol same as AMD? Uh, and then would you prefer aflibercept actually?
Yeah. Will you prefer aflibercept, PRN, or treat on extend? Which one is your preferred protocol?
So this definitely 3 loading doses of aflibercept are required, and then you follow it up. And here the follow-up has to be with ICG, and it cannot be just a blind treat and extend, because the polyps in some cases may completely regress, in which case the recurrences may be less, and overall prognosis is different from that of an AMD patient, where it doesn't go off completely. So it has to be PRN after some extent. You have to do a repeat ICG at least after 3 months or 4 months at some point of time to see what is actually happening to the polyp. So it cannot be just a treat and extend, which is followed for AMD, and especially in presence of polyps. If it is just a BVN, then maybe you can consider
Yeah.
one
Dr.
series.
Angelika wanted to know that if we go focal laser to the leaking points, the pachychoroid pathology will still persist. When should we go for
Yes.
PGT and when to go for focal laser?
So Even if you do PDT, the pachychoroid pathology will still persist. So which is why there are recurrences in PCV, which is why
Correct.
recurrences happen not only from the same place, but in a different place. The polyps can occur elsewhere. So which is why it has to be dealt as a different entity. So
Yes.
to know where thermal laser can be done and where PDT can be done, so subfoveal lesions have to be treated with PDT. And if it's a juxtafoveal or an extrafoveal, I would prefer juxtafoveal and subfoveal to be treated with PDT. Extrafoveal, you can consider thermal laser, but that too, if you're worried about the scotoma that thermal laser can cause, you can, and there's a large cluster which is sitting together and the patient is ready, you can ablate the whole area with PDT, even in an extrafoveal lesion.
Agree with you. Anshu also had a question that in a large lesion, almost covering the entire macular area with an area of RP atrophy and BVN, how would you suggest doing a PDT? Will you do a full fluence with multi-spot or monotherapy with a VEGF?
Yeah, so there are two ways of doing it. First of all, when we started doing PDT, we used to do a FFA based PDT spot, we could see. But FFA based PDT spots were much larger because actually you are supposed to cover all area of hyperfluorescence. So here on FFA, the PED also becomes hyperfluorescence. So it is a large spot. Then we moved on to ICG based PDT spots where only the polypoidal and BVN was involved in the PDT. Later, it was realized when we saw the treatment outcomes that actually the BVN persists even after multiple PDTs are done. So you could probably target only the polyps also. But preferable to cover the polyps and BVN. But if you think it's a very large lesion, then you have the option of only treating the polypoidal lesions in the PDT. And anyway, you are going to give a combination with an anti-VEGF, which takes care of the BVN as well.
Dr. Chekitan,
And
he
I
wants.
think she asked about the reduced fluence and full fluence also.
Yes, full
So
fluence,
I
correct.
prefer the reduced fluence most of the times. So it reduces the complications that could be associated and is equally effective.
Yes. Dr. Chekitan wanted to know that in a patient with a history of cardiac problem on anticoagulation, which anti-VEGF will you prefer for treatment in terms of systemic safety?
So here the anti-VEGFs are all of them will have some issue or the other. And you have to talk to the patient, discuss with the patient, have a cardiologist's opinion, see how bad is his cardiac status. It's not that once you have a cardiac issue, and most of the patients who've undergone a bypass actually after that become quite stable, and their cardiologists are okay with it if you give a. So it has to be in consultation with the same way as you would deal it in the AMD patient. It has to be in consultation with the cardiologist. But if you are asking me specifically whether those patients can be given by steroids, steroids generally don't really work too well in PCV, and we have to look at some way of giving. PDT is a safer option. You could definitely do a PDT.
I think the same guidelines they are there, which is for AMD or a DME. Whenever you are injecting anti-VEGF, today the guidelines are keep at least 3 months. If there is some cardiac event, after 3 months you are safe to give. But yes, as you rightly said, it's better to have a cardiologist opinion. But in general, 3 months is the window period. Dr. Manoj Saswade wanted to know at what time intervals you give the first 3 loading doses.
What time intervals you give?
The
Please
first
come again,
3
Rajiv.
loading doses. What is
Okay.
the interval in
So
between
these are
doses?
these same thing. 4-week interval is what is followed for PCV also, same as what we follow for AMD.
Dr. Gaurav wanted to know what is the energy endpoint for thermal laser in macular PCV.
So I always treat a polyp in the same way as I would treat a tiny CNV. So there are very nice guidelines available from the MPS criteria how you would treat extrafoveal CNV. So the same procedure you have to follow. So when you outline the polypoidal lesion, you give overlapping burns. make sure half of it is inside, half of it is outside. And since they are smaller, you could probably go a little more around also, and then cover the whole area of the polypoidal lesion. So I primarily treat them like tiny CNVs and treat them accordingly.
Yeah, Dr. Parveen, rightly what you said, you have to follow the MPS guidelines. And the power, what he is mentioning, you are not looking at blanching of microorganisms. So here it is chalky white burns. What is
Yes.
classically being described, that you use a higher energy, use something which causes a chalky white burns. And if Dr. Parveen will also agree that when we used to do laser for these juxtafoveal CNVMs, it's good idea actually the same way to do a pre and post, do a overlay and see whether you have done a complete coverage as far as laser is concerned. I used to do it very regularly initially, but this is something which is a tip when you started doing laser for your CNVMs or a PCV. Uh,
Yes, I agree. You can do that.
yes,
And juxtafoveal prefer to do a PDT, but if for some reason you are not able
yeah,
to do,
not
I sometimes
at this
leave
stage
the
it is
foveal.
correct.
Yeah, I sometimes leave the foveal edge untreated and give an anti-VEGF along with it or something. I mean, if you
Yes.
really are pushed to do these kind of things, but preferably juxtafoveal also I would put in the category of PDT safety.
Yeah, I agree. PDT today, this I'm talking about the era when PDT was not there, it was
Yes.
only TTT. And we used to treat these laser, we use laser for treatment in some cases. Uh,
But thermal laser is a one-time treatment for the patient. So
correct,
if you can
correct.
painstakingly do ICG, sit, a little difficult to correlate the ICG with the clinical fundus picture. But if you do that and correlate and look for these lesions and treat them, the patient will be a very happy person, and you can multiple visits to the hospital and all can be avoided. And if you have a subfoveal lesion along with an extrafoveal, don't hesitate to do thermal laser to the extrafoveal lesion while you are doing anti-VEGF or PDT for the subfoveal one. So
Yes.
it works that way also.
Dr. Gaurav also had a question that do you foresee that OCTA will replace ICG in our diagnostic armamentarium?
I think so. It may happen. See, for AMD, I think for CNV, what for AMD, I think largely we have moved over to OCTA. It gives us almost all the information and more. So, few cases you may still want to do maybe things like asteroid hyalosis where the OCTA doesn't show you, but FFA will show you the picture. So few specific things are there where you would want to do. But as our technology improves, as the penetration of the wavelengths into the choroid improves, I think I showed you the last article from JAMA. So they have shown what ICGA could not show, and the depth resolved. Whether there is always a controversy whether the BVN is below the Brooks membrane or it is above the Brooks membrane. So all these are going to get resolved only with the better imaging technique, which can happen with ICG. Sorry, OCTA.
I fully agree with you, Dr. Parveen. As you know, whenever we do any diagnostic procedure, we are looking at only two things. One is diagnosis of a disease, and based on that, the treatment. Now, APOI's guidelines or APOI's consensus group, which you presented recently, the ophthalmology article, it does suggest that OCT seems to be enough for diagnosis of PCV. The only problem now coming is for treatment. As I mentioned, you even for monotherapy, if you are planning to treat only with anti-VEGF, things are working. But the moment you want to treat it with a PDT, you definitely need ICG at this stage. So probably once we get the imaging to that level, that with OCTA combination with probably a structural OCT-B scan, we can very reasonably localize these lesions, detect all of them. I think that is that time that OCTA will totally replace the ICG.
And especially things like peripheral PCV, again, you don't have the answer in OCT. You will still need
Correct.
ICG. So there are
Correct.
going to be specific places where you will need ICG, but still, I think almost 50 to 60% of your work in PCV can be handled with the OCT.
Okay, I'd just like to ask you a question. Have you sensed or are you aware that there are differences in the clinical appearance of PCV that we get in India versus, let us say, in Singapore or Japan?
Dr. Nangia, I couldn't hear you well. Are there differences in the PCV?
In the PCV appearance or the clinical presentation, patients from India versus patients in Singapore or Japan?
Not really. I think the difference comes between the Caucasian population and the Asian population. So largely the Asian have been sort of grouped together. Or if at all, some reports have mentioned that the hemorrhagic component is probably more in the Indian population vis-a-vis the exudative component, which can be more in the Singapore or the other Asian countries. Caucasian population, I think, largely sees the component, which is the one with thin choroid, and there are aneurysmal dilatation at the end of a type 1 CNV, which is why they name it as the aneurysmal type 1 CNV. They don't want to name it PCV. So, but this consensus article, one good thing was it had a fair amount of representation from the West and Asian countries both. So both of them have sat together and done this. So I hope this divide of Asian and Caucasian will slowly become lesser, and we will start treating PCV as a whole disease entity. And we will know, and as I shared the genetic information, it will probably show us that ARMS2 is present in AMD patients, and maybe there is a particular allele which is present in these patients with PCV, which gives rise to a polypoidal lesion as well. So, this paper was important because the heading of the paper is imaging and genetic correlation. So they are applying genetics to the imaging markers. So which is what is probably now going to happen. We are going to see more and more of it because now we are becoming sure of our imaging. We know that this is what it is. So I guess then this boundaries will become less.
I agree with you, and I think the genetics will play an important role. And I would just like to share one of our study which we have done, where we identified a mutation in PCV, which was very specific for PCV. We also found one mutation which was related to treatment response, and we actually developed a deep learning algorithm. By retinal image, we were able to predict it to accuracy AUC of more than 90%, whether it will respond to anti-VEGF or not. And this was published very recently. It's a small sample, definitely, but what I'm telling is we will have many of these things which will come in future, where genetics probably may play an important role even in determining the treatment response.
Rajiv, do you want to make any concluding remarks? I don't think we have any more. There is one more actually.
Yeah, we'll cover that. Chekitan. So yeah. Chekitan wants to know that in today's scenario, which OCTA machine do you think is best in terms of resolution and diagnostic quality and reduced noise?
Well, that's a difficult one. See, this is something which you have to, actually, if you look at the Heidelberg, it kind of covers a lot of things. It gives you the option of having various things put together in one. You have imaging, you have ICG, you have multicolor, you have OCT, and you have SD OCT, and you have SD OCT-A also, and you have the enhanced depth imaging. So this, you have to see what is the need in your clinic, whether you really need all these things. And now even the other platforms like Zeiss also is coming up with a lot of these combination instruments. The Heidelberg comes up with the option of an interior segment OCT also. So, but the cost goes up phenomenally. So it is, I think you have to draw a balance between, it is almost like, I think, buying a new smartphone. So you have to see whether you really need all these apps, and then you decide whether you want to pay so much for it. So you really have to sit down with it, see whether you really need them and how much it is showing you before you buy it. So I think different machines have their different advantages. Swepso's definitely, because it has the technology which is such that uses a higher wavelength. So at this point of time, the penetration, the depth of penetration is better with Swepso's. There are a lot of studies which have said that it is better than even the SD-OCTA. Though SD-OCT gives you the EDI, but still the visualization is, the deeper penetration is better. So these are the few ways I think it can differ. Rest, I think you can explore the market and see which company is giving you a better deal and then take a decision.
I think for PCV, as you rightly said, it is SSOCTA. You take Zeiss Plexilite or you go ahead with the other companies, but that's something which would be a gold standard as far as PCV is concerned. Each machine has got its own advantage and disadvantage. To also look for the analysis which each of these machines give, because some of them capture all the capillary network, especially in DME things are a little different. So I think for as far as PCV is concerned, I would suggest SSOCT.
And the SSOCTA actually is not widely marketed even now. So
Yeah,
it is still, they are kind of evolving, and so probably you can wait for a while and see whether they come up with something and then take a decision. It is also from the Zeiss, so you can probably wait and see whether they're finally ready for a large scale marketing and sharing it.
Gaurav just gave us a suggestion about the Topcon Straton gives MMI without ICG, but with Swepso's OCTA and point-to-point correspondence. MMI, I am not very sure what is the full form.
Multimodal imaging.
Okay,
So
okay.
multimodal imaging with
without see
people
nowadays
who
there are
use a
so
lot of
many of these
abbreviations.
terms, no? In retina,
Yes,
even
yes.
I'm not very so good. Good, you caught it. So it gives multimodal imaging without ICG, but with a Swepso's OCTA with a point-to-point correspondence. So that's a SSOCTA. That means it's pretty good for your PCV.
Yes,
As I told you, it
exactly.
looks
It will
good.
be good.
The probable advantage of Plexilite is the larger. I'm not sure whether how much millimeter Tropcon Triton OCTA gives, but here you can, with a montage, you can have really a large 12 millimeter scan. That is the advantage of
All
using
those
the.
things are, these things are evolving. So over another year or two, you will have even large scans.
Correct, correct.
So this is something which is going to, so you
Yes.
can definitely look at the option of upgradation, whether you have or not in all these OCTs that you buy.
I don't see any questions now. Dr. Saran, do you have any
Ma'am,
questions or any
I had a
comments?
question.
Please.
Yeah, it was a fantastic presentation, ma'am. Very well given. Just a small question:
Thanks, Sam.
how far you go in treating the sub-RP fluid?
Sub-RP lesion, the BVN.
Sub-RP fluid.
Fluid.
No, the fluid, the PED.
Fluid. Okay. So this sub-RP fluid is actually more relevant where AMD is concerned rather than where PCV is concerned, because sub-RPE fluid is nothing but fibrovascular PED. So that fibrovascular PED, usually those kind of PEDs you don't see in PCV. You see hemorrhagic, you see serous PEDs. So for AMD, we are still, the consensus is that if the sub-RPE fluid, or as you call this fibrovascular PED, is the same thing, if it is not associated with any SRF or any IRC, intraretinal cyst, you are not going to treat it. But on a follow-up, the increase in height of a sub-RP fluid or the fibrovascular PED is an important biomarker that this could go into an active disease anytime. So you need to see them and watch them much closer. So you could add a height of the PED into your armamentarium of biomarkers, because that is very common in a type 1 CNV. In PCV, we usually have a naked kind of a branching vascular network, which gives rise to a DLS. So this DLS is also like an elevation of PED, is like a flat PED, but the inner echogenicity of this is of a moderate or a mild kind, while in a fibrovascular PED, it's almost like a solid lesion which is sitting there.
Yeah.
The height of PED is what you can watch for. You will
Once
never
the
be able to
height,
flatten. And if there are studies who have tried to flatten the PEDs and they've associated it with high chance of macular atrophy. So the TURF study and all
yeah.
was done to flatten these PEDs. But I think the flattening of these fibrovascular PEDs causes too much of drying and macular atrophy. So that is not advised really. The consensus is not to do that as of now.
As Dr. Parveen rightly said, you look at the height of the PED. Another characteristic which you can look at is a thin cleft of fluid. Sometimes you see below at the base of that PED, and sometimes you even see at the top, you see a hyporeflective area just beneath the PED, and then there is that hyperreflection that indicates fluid there. So it can be a fluid accumulation above or below. So besides the height of the PED, which is a quantitative and a very good measure, you can look at these qualitative signs also for the presence of activity. I think we are through all the questions. It was really a pleasure having Dr. Parveen, your good insights on PCV, and that keeps the ball rolling for this imaging symposiums, the series of which Dr. Vinay Nangia has very rightly planned. And thanks again for being with us and giving this beautiful lecture. Dr. Vinay Nangia, your final words.
Thank you very much, Dr. Parveen. You did a great job, and there was so much knowledge that you've given to everyone who was attending this. And we just understand how challenging these things are. And it reminds me of one of my colleagues saying that, when I said, what's the focus of ophthalmology? And he said, it's 6/6 vision, And I think that PCV is perhaps one of those diseases that tells us that you need to keep on struggling to give good vision, actually. I think that the great challenge is the non-availability of ICGA to many of us, and also that the OCTA is not so helpful. And perhaps it was very right that the OCT was considered perhaps to be a very important tool for many of us to diagnose. And but I think that there may still be some limitations with using the OCT in treating this condition, I think. So I think that's the great limitation. Once again, thank you, Rajiv. Thank you, Dr. Parveen. And thank you, Dr. Sarang and Prabhat, for having done all the background work to get us going, actually. Thank you very much.
Thank you.
Thanks, Dr. Nangia. And I'm going to be a constant attendee of your imaging sessions. So I'll definitely be there next month as well. This is a very good platform. I think it helps you discuss at length each small aspect of imaging. It's a very good initiative indeed. Thanks a lot.
Thank you so much. Thank you, and bye-bye.
Thank you.
Bye-bye.
Have a good Sunday.